Okay, very good. Thank you again. Now we are moving to the master of the open Latarjet. I will not have any question about the indication for Gilles because I know the indication for Gilles is Latarjet. So I want to listen from him a master technique lesson about the Latarjet. Gilles Walsh from Lyon, France.
Thank you, Alex. So this is the very first picture from Michel Latarjet back in 1954 when he published the first time his procedure. You know that he did a split on the subscap and he just screwed the thoracic process on the glenoid. Yeah. So it's important to remember a little bit about the story of this procedure. Elfet reported the Bristol procedure 4 years after the first paper from Latarjet. Moreover, Elfet did not perform really what we now call the Bristol Latarjet procedure because he did not recommend to use a screw. May in the U.S. was the first one in the U.S. to recommend to use a screw to attach the coracoid process to the glenoid. So there is a big gap between the first procedure described by Michel Latarjet and May was using the same technique. Didier Pat in France modified a little bit and popularized in France the procedure, and he did really. Can we go back to this one? He popularized in France this procedure, and he taught me this procedure, and he said that this procedure has a triple blocking effect. First, by increasing the anterior-posterior diameter of the glenoid, that is a bony effect. Then he reattaches the capsule to the stump of the coracoacomal ligament, and this is a ligament effect, or the Bankart procedure. And third, it is a sling effect of the inferior part, intact inferior part of the subscapularis, which stay down and prevent any recurrent dislocation. So our indication for this procedure right now are any kind of recurrent anterior dislocation or subluxation with or without hyperlaxity, with or without bony lesion. As a matter of fact, we have two contraindications. The first one is a painful shoulder in the throwing athlete with no Bankart lesion. And the second one, of course, like everybody, is a voluntary anterior instability. Otherwise, we systematically use the Bankart procedure, Latarjet procedure, because of our results. So we have now performed a little bit more than 2,000 cases during the last 25 years. Regarding the technique, there is a video on the VuMedi that is available for everybody, so I will not go through, and just remember that we perform this procedure in the beach chair position, and please go on the website on the VuMedi and you will see the full video. The hammock effect of the subscapularis, the inferior part of the subscapularis, is probably the most important effect because this inferior part of the subscapularis will stay inferior against the glenoid because of the conjoint tendon. And even in the abduction external rotation position, the inferior part of the subscap will still prevent the dislocation. So this is a typical aspect on the X-ray and the 3 plan on the coronal, then on the measure view, which is a profile, or in the sagittal or parasagittal. So you see that the screw are usually at 5 o'clock and 4 o'clock, at 6 o'clock, and we try to have the screw exactly parallel to the glenoid. The clinical results were published several times in this series that with 4 years follow-up, we reported a recurrence rate of 1.3%, but the subjective results on return to sport were excellent in our series. It has been said that the Latarjet procedure is responsible for a lot of arthritis. With the French Society of Orthopedic Surgery many years ago, with Christophe Levine, we organized, and Henri Coudan, we organized a multi-center study in order to compare a large series of Latarjet and Bankart with more than 10 years follow-up. And Christophe Levine was in charge of reviewing the patient with more than 10 years for the Latarjet procedure. And he showed that the rate of arthritis after 10 years was exactly the same in the Banca procedure and the Latarjet procedure. And as a matter of fact, we were able to show that the procedure is not responsible for arthritis. What is the cause of arthritis for anterior instability is time. The time means the age and the delay, the time elapsed after the surgery, and the bony lesion on the glenoid or on the humerus. So we did not find any difference between the soft tissue procedure and the Latarjet procedure regarding the rate of arthritis. And I think that it is very important to remember. Remember also that almost 15% of our patients have already some arthritis before the surgery. And whatever the surgery you perform, whether you perform an arthroscopic open Bancart or arthroscopic Latarjet open Bancart, you will have anyway arthritis if the patient is older than 40 years old, has already some arthritis preoperatively or a huge fracture. So it's not a good, it's not right to say that the Latarjet procedure is responsible for more arthritis. That's true that there are some complications and some variation regarding this technique. And in order to compare apple with apple, it's important to understand that every single surgeon who does this technique modify it a little bit. So either you put the coracoid above the normal subscap, and I think it's not a good idea because there is too much tension on the conjoint tendon, or you can cut completely the subscap or only 1/3 in the middle like Latarjet, or only the inferior third, or split it or perform a L like Didier Pratt did. Well, there are many different, and I think that operating on shoulder instability, anterior instability, it is crucial to preserve the subscapularis. Most of the problems related to surgery for anterior instability are related to the subscap tear or re-tear or tenotomy. So try to preserve at any price the subscapularis. There are also variations among the authors regarding the coracoid process. Some of them, as Pascal Boileau said, may prefer to put it in the standing position, as we see here, or like Bristol here, or like Pascal Boileau recommended to do early on. It can be like De Beer and Burkhardt on the side of the coracoid process, or it can be also in the lying position. We prefer to have the lying position because we have more surface contact in order to avoid the non-union. Regarding the open reduction internal fixation, we can use either 1 or 2 screws, 3.5, 4.5 malleolar, 6.5, with or without washer. So many different variations, and these explain why it is almost impossible to compare the articles and the results in the literature because, again, every single surgeon modifies the technique. Regarding the capsule, again, you can either just forget it, abandon the capsule, but not repair it like this. You can repair it like we like to do, a Bancart procedure, by reattaching the capsule to the stump of the coracoid ligament, or you can do like a De Beer, to reattach the capsule to the anterior part of the glenoid with 1 or 2 anchors in order to have the coracoid process in the extra-articular position. You can also try to do like we did here, some kind of capsular shift or some kind of capsular sophisticated procedure. We just abandoned completely this kind of capsular procedure because we did it to treat constitutional laxity. And whatever I did, I found out that after 1 year, the laxity recurs exactly the same as first. So this procedure is not designed to treat the hyperlaxity, the constitutional laxity. It is designed to treat instability or pathological laxity, and this is completely different. Complication has been reported. You have heard about that. Coracoid non-union between 0 and 26%, coracoid fracture, subscapularis fat infiltration, and arthritis. Let's have a quick look how to avoid the complication. So that was this first, how to avoid it. So we recommend to use a long piece of coracoid process, 3 cm to 2.5 to 3 cm. The coracoid in the lying position in order to have a better surface contact, and perform a careful decortication of the coracoid and of the glenoid. It's better to use a 2 screw because you don't need to tighten up too much, and you avoid the problem of rotation, and always use bicortical screws. look at all these examples. All of them were performed with one screw, unicortical, and all of them failed because of the non-union. So in order to avoid that, the coracoid in the lying position, 2 screws, good decortication. Another complication is a fracture. How to avoid the fracture? In our experience, this was related most of the time when we use a 4.5 cortical screw. That means that we had to do a pre-hole on the glenoid with a drill bit 4.5. It's too big. The coracoid is too small bone, and it's better to drill with 3.2. And this is the reason why we like to use a malleolar screw, because even though it's 4.5 malleolar screw, we have some compression. So it's what we recommend now, the malleolar screw with 2 screws, not over tight on the coracoid process. How to avoid the subscapularis fat infiltration, which has been reported to be between 20 and 41% fat infiltration. So this is very simple. Perform an horizontal split and avoid to cut the subscapularis, because even though you do a good repair, good suture, in this young population, the rate of tear, secondary tear of the subscap is pretty high. And it's extremely difficult to do a revision of such a patient with a failed subscapularis and recurrent dislocation. So horizontal split is a little bit tricky, a little bit difficult to do, even open. We have seen with a fantastic technique of Lafosse and Pascal Boileau that it's difficult to perform arthroscopically, but I can tell you that also it's not so easy to do with a mini approach open. So we have to practice in order to do it, but once we are able to do it, this procedure is very safe, because if you don't cut the subscap, you avoid a lot of complications. How to avoid arthritis? Well, it's very simple, very easy. You just need what you see. That means that you should not put the screw if you don't see what you do. And also what is important is to avoid any overhanging, either of the coracoid or of the washer of the bone of the screw. So definitely arthritis are related, as we said, either to age, time, and fracture of the glenoid, or of course bad surgical technique. So this is easy to avoid, and this is just related to exposure. If we are not able to expose correctly the anterior inferior part of the glenoid, it's probably better to not perform the Latarjet procedure and to do any kind of other procedure. So in summary, is arthroscopy the future? Yeah, I would say probably yes. I remember that 25 years ago, when we started to do the cruciate ligament with the scope, nobody believed that that was a technique of suture. So I think that what is doing Pascal and what is doing Laurent Lafosse, I think is the future. But personally, I will wait. I will not try to do it. And I will wait that Laurent and Pascal report results with no immobilization, activity of daily living possible after 15 days, and contact sport after 3 months with a recurrence rate of 1%. Thank you very much for your attention.
Thank you to you, Gilles. Perfect presentation. Again, like always, I'm not asking you anything about the indication because you were very clear, and I greatly appreciated the fact that you outlined the potential pitfalls and how to prevent them. Then, although you are even a little better than God, because your recurrence rate is 1 and God is 1.8, but in that case of the 1%, what is your attitude then? How can you manage the very rare recurrence rate of the last?
Depends on the cause of the recurrence. If the recurrence is a subscap tear, it is a very difficult problem. I just put a big, huge bone graft from the iliac crest in order to have a glenoplasty effect of the bone graft. It's a Eden-Ibanez procedure, and I try to repair the subscap as much as I can, but usually because of the retraction, there is a complete fat infiltration, and we cannot repair it. So it's a drama, a big catastrophe if there is a failure of the subscap. Now, if the subscap is correct and the problem is related to the coracoid process, what I recommend either for non-union or fracture or pull-out, I recommend to do a Eden-Ibanez procedure. That means that I take a big cortical iliac crest bone graft, and I split the subscap again, and I put it in the correct position with the 2 screws again. And we reported the results recently, and we had almost 90% of satisfactory results with Eden-Ibinet after a failure of Latarjet procedure.
Okay, thank you very much. Okay, now we are